everybody. Welcome to In the Know with Nina. I'm your host, Dr. Nina Crowley. I'm the Director for Clinical Education and Partnerships at SICA, where we partner with healthcare providers to offer body composition solutions. Today, I'm joined with interventional cardiologist, Dr. Arasi Moran, and she's at MUSC here in Charleston. I'm glad to have you on. Thanks for joining me.
Thank you so much, Nina. It's always fun to have a chat like this.
So tell me a little bit about your background because you have so many things that you're expert in. I didn't want to, butcher any of them.
No, no, no. So I am both certified in internal medicine, general cardiology, and interventional cardiology. Interventional cardiology basically means you're a glorified plumber of the body. You go through the blood vessels in the heart and open up the blockages and put stents. So I am the director of the Complex Coronary Interventions Program and also the cardiac cath lab director at the Ralph H. Johnson VA Medical Center. And now this.
Wonderful. Well, I was really excited to bring you on because in our world there is a lot of buzz about obesity medications, and so our worlds are kind of colliding. A couple
Absolutely.
months ago, the FDA approved semaglutide or Wegovy for the indication of heart disease, and so I'm really excited to dig into that with you and hear about how that's impacting your field, what skills you guys have in the treatment of obesity, and what you need to make that a better comprehensive care part of that program.
Absolutely. So, Nina, before we get into that, why don't you tell me a little bit about the behavioral aspects of obesity? Have worked with so many obese patients in different categories. Yes, my husband might be the surgeon, but I think the patients spent more time with you than they did with him. So, can you tell me what were the biggest behavioral challenges with regards to obesity management?
Yeah, they do. They do love to get their picture with him though, and he loves to smile for those. So I'm sure he's got a whole bunch of those on his phone.
Yeah.
But yes, I so in working with bariatric patients, people who've had weight loss surgery over the years, 18 years of that has really been. I mean, that's fundamental for me understanding obesity, and the biggest thing that I always tell people I learned about obesity is that when I went into nutrition, I thought that I was going to learn the best evidence, the best way to talk to people, the best information, and that I would go into a room, tell people what I knew, and be able to change them and help them do the things that were the best, and then they would have a really good outcome. And so that, of course, took weeks in the job with patients who have surgery to really understand that that was not how it worked and that it was a whole lot more complicated. And actually, I found that patients who have obesity ended up knowing a whole lot more than sometimes than I did, or sometimes than I gave them credit for. And so I think there's a lot we can learn about what people know before we jump into telling them what to do and being, more top down or advice giving, because they have struggled with this condition, many of them for their whole life. And so they have tried and not had success and had success at many different things over the years. So I always take a real curiosity approach from, where are you to start? Because even our initial assessment in nutrition, we are often sort of like, what's your history? And we need to know like what has worked for someone in the past. Where are they, where did they have success? Where did they struggle? And often I would learn so much that people have tried so many different things. And over the years we've gone from a real carbs are the enemy to fat is the enemy to back to carbs are the enemy, and protein tends to be left alone for a little bit. So, at least we're there right now. But the thing that I've learned actually is really that a different approach is going to work for every patient differently. It's just how we sort of get there. And for me, the skills have been a lot more about how do I get that person to like understand what they like, what they want, what's available, what's in their culture, what's their enjoyment of food, and then take and sort of put a lens on how do we make that align with whatever health condition they're trying to manage, if it's obesity or others, and then kind of merge those two together, but get them to be excited about figuring out how to make that happen. Because we've all done this. What's the best? What's the perfect? I mean, you and I've even talked about that. Let's follow this for a little while. And, we all do that. And for most people, majority of people, if you ask them a year later, they're like, what was that I was doing a year ago? Some rigid thing that we're trying to prescribe to. So I definitely felt like the approach of understanding people's history and background and their likes and their needs was a real big take home for me in learning psychology to apply to nutrition. Sometimes you don't even get into the food.
Yeah, absolutely right. Food kind of becomes a afterthought. Oh, it's because of this, and I need an outlet for this particular feeling I'm having. And I truly understood, at least for my own self, like when I went into like a health quest on for myself, and I turned 40, I was like, this is it. I have to reboot my own self. The biggest question was, why am I so addicted to chocolates? Why do I, and the reason was, it's not the chocolate, but it's the memory of a simpler time in my life when I was completely irresponsible. And it was just that warm and fuzzy memory, which was associated with chocolate, which took me back to that same point every time I had chocolate. Then I was like, oh my God, so disassociate. How can I have the same warm and fuzzy memories without having a bunch of chocolates, And I'm sure, and then it's same thing for stress management or anxiety. You don't even taste the food you're eating, and you're just eating, and it becomes a habit, and how to break the habit loop. So I
It's
truly enjoy
complicated, that's for
it.
sure.
It's complicated, yes, and that's why there's so many of us in the space, right? You are attacking it in one different end, and I'm attacking it from one different end, and but we're all on the same thing. It's all about health and longevity. And this is something we should be able to make it a little easier for people than how it has been. And so far, we are all losing this battle, given that so many of us are in this space, tells us that we are losing the battle.
Well, I think what's interesting about that too is that when you bring up sort of the conversation that you're having internally about chocolate in particular, is the concept of food noise. I don't know if you've heard a lot of
Oh,
talk
yes.
about that, but
Yes.
with the semaglutide and the GLP-1 receptor agonist, patients are really describing almost this new phenomenon, though we saw this in bariatric surgery for years, of this reduction in these intrusive, intense thoughts that are about food all the time. And so I think that's, whether or not they're on these medications for life, that remains to be seen. But I think for even a short period of time, reducing that food noise and thoughts that people have is giving them a real interesting perspective on being able to do the stuff that they may have learned or know. Like I said, a lot of patients came to me knowing what they were supposed to do and knowing what a really healthy way to eat would be, but these other things got in the way. So for me, even outside of the weight loss and the comorbidity changes after taking medication or surgery, the thing that I felt is so interesting and important is that they were able to have mental space to be able to work on the things that they want and intend to do, but maybe struggle to actually put into play long term to execute.
So let's kind of deep dive into BMI. I'm sure you will agree with me when I say it's a useless metric, and people are obsessed with that metric because it's weight and height and your body. It does not delve into body composition.
Right.
And I believe in body composition, and I'm sure you believe in body composition, given the fact that you are kind of heading this whole medical program. What are your thoughts about the focus on weight and the focus on a number on the scale as a measure for obesity?
So many thoughts. Let's see if I can organize them cohesively. So I think the first thing is really when I do a lot with policy as well, and so I was part of the movement, over a decade ago, where we were really trying to get obesity recognized as a legitimate chronic disease. And so
Mhm.
in that effort, you needed to have a way to assess and stratify people into that. And so there's a very long history with BMI that I won't go into, but kind of picking up from 2013 when obesity was recognized as a disease by the American Medical Association, that was when we were promoting, let's use BMI because this is a way to screen people. And we're just hearing a lot more and more about how the coming up with BMI has a complicated history in, an all white population, a mostly male population, definitely not a higher weight population connected to insurance and lifespan and all of that. All of that aside, at first we were like, BMI is needed to help give it a, ICD 9 or whatever it was
Code,
back then
code,
code.
healthy code.
a billing code to be able to sort of bill. So if we're going to talk about obesity as a real disease, there needs to be coding, there needs to be reimbursement. And so 10 years after that, I don't know that it's fully, integrated into all the health systems, but we've sort of, been able to say now we know what the prevalence of people at these particular BMIs are. Problem is they were never really intended to for the individual to be able to then say, okay, you have this, here's what to do, or what they can do with that information. So part of that is a screening metric, because it was free and cheap and easy, and two numbers divide, it's a calculation. We applied that to everybody. We sort of missed the boat on, well, we need a little bit more intervention, or inter um, personal number that actually matters to that person and is related to the intervention, right? So that's where I'm seeing, the past couple of years, really ever since I've left my role at MUSC in the bariatric department, I've been in this world where I'm talking to providers every day about what they can do to better measure it. And they are finding that measuring body composition gives them a whole lot more um, ability to target their treatment plans to the individual. So I was at a conference this past weekend even where they were talking about normal weight obesity, where they're missing, people who have a normal BMI, who have a body fat percentage that puts them at high risk. And so that's really where I think it's getting interesting, is that we're seeing an uptake of more and more providers saying, okay, we've been now saying BMI is not the best for a few years, maybe some of us maybe longer. But what I haven't seen is people really committing to what that next measure is going to be. And so that's where it's been exciting for people to say, okay, there's some ways that we can measure body composition. There's some gold standard measures. For fat mass, there's a few ways. The 4-compartment model is the best. It takes air displacement, it takes bone density, it takes weight, and it takes water assessment of water with deuterium water dilution, right? These 4 things, measures them, puts them into a complicated algorithm, and that's one of our best measures for fat mass. With muscle mass, we're
That's
looking at
not,
MRI. None
yes.
of that's clinically feasible, but these gold standard measures we then compare with something like bioimpedance, which is the work that I do with Sika. Is we make a scale that measures the electrical current going through the body through different tissues at different speeds, and we're able to say, this is how much fat mass you have, this is how much fat free mass, and then drill that down to muscle mass. And muscle mass being validated with whole body MRI, it's a pretty good measure. These are 97 or 98% in agreement that the measurement from 4-compartment or MRI is in agreement with the bioimpedance measurement. And then we can really say, let's do that in a clinic. You don't have to leave. You get that done. We can talk about it that day. We can make adjustments. We can say, hey, I'm going to treat somebody who's this weight, who I would never have suspected had that much cardiac risk,
Yes.
differently, because their body fat is both high and all around their middle. Or
Mhm.
I'm going to treat this person whose weight is very high, but their muscle mass is so low that I'm not going to put them on the most intensive medication or surgical treatment, because I'm afraid of them losing too much muscle. That's where it's really getting to this sort of precision or personalized nutrition, or intervention for their obesity. And that's what I think is really exciting.
So I want to kind of take a step back. In general, in medicine, the gold standard for body mass composition has been DEXA scan, which involves radiation, or MRI, whole body MRI. No insurance company is going to pay for that, or the body parts or the air displacement, things like that. So those are technically difficult. It requires, radiation exposure or payment with cash, etc. And also, you can't be doing serial measurements of that because, again, radiation exposure, etc. So you are saying body impedance can change the way we look at obesity, and they can, the toffee thin on the outside but fat on the inside individuals, we can actually capture them and give them more personalized treatment. I mean, I think that is a fascinating way to look at patients or everyone. And kind of, what do you think about, I've seen advertisements for so many of these scales, $20, $25, and it gives you a fat composition and muscle composition. How accurate are they, or how believable is the number coughed up by those
So
machines?
any of those smart scales, they tend to call them, there's a few important things to know about them. Anything like that you're stepping on at home, that's just your feet, is going to measure the electrical, it's bioimpedance, and it's going to measure the conductance from one foot, through the legs to the other foot. So it's not a whole body assessment, but in all of these, really the only direct way to measure body composition is autopsy. So anything else is not a direct measurement, right? So this one's taking the bottom half of your body composition and putting it into some, algorithm where it's extrapolating to the top half.
Okay.
And for some people that's good enough. For most people, and especially those who have obesity, that's not going to be an accurate, a fully accurate assessment of the body. So one of the things you're looking for in bioimpedance is that it's going from feet out through the hands. So you can really look at the arms, the legs, the trunk, and take those. And then there's, again, prediction equations that validate these to those gold standard measures. So, the thing about the gold standard, which I've been thinking a lot about that term, and I think we kind of need a different term. But if we take a reference measure, right, whether it be DEXA or MRI or the 4-compartment model, which includes DEXA in there, if we take one of those reference measures and we measure something with bioimpedance and we're getting 97 or 98% agreement, we're feeling pretty confident that compared to something like BMI, which we're all saying is completely off, we're good enough. We're 98, 97% very
That's
confident
pretty good.
is good enough. And then the other thing with the home scales that, we do have to think about, like, how this technology works. Your legs need to be apart so that you can run that the electrical current through the legs. And if you're standing together on the plate, if you're in your bathroom naked, standing and your legs are super close together, it's not going to get a good measurement. And then for people who are people with obesity, they might not even be able to get on that small base scale. So there's some factors there that are tricky. But what I will say is people like to have something at home and they like to trend, right? So there is a value in trending data at home, even if it's not the most accurate. We usually recommend that your doctor's office has a body composition device in the office that you can then go to and get a good assessment. The other thing that I've been talking about a lot as a behavioral focused person is, how people react when they get on the scale every day, right?
Yes.
There's a handful of people, not a handful, there's a subset of people who that's a real part of their long-term plan. They get on, they see where they're at, they make adjustments. That really works for them. There are some people who get on there and seeing that number causes them distress, and that makes it completely worse because they don't do those things during the day that they need to do. And then there's some who get real obsessed with the number, and not only is it just not helpful, but it's actually detrimental to them. And so my worry is that for people to have that one data point of weight at home every day or multiple times a day, for those that can be problematic for getting data about your body composition, which we're not wanting to assess a change from day to day. In the office, we recommend 4 to 6 weeks at minimum because you want to see an actual change in body composition. And if you're measuring it too frequently, you're going to get the noise in measures around hydration a little bit. And, people, oh, did I gain 2 pounds of fat? Did I, what's happening? Oh, well, what did I have for breakfast? Well, I'm not going to have that again. So people's thought patterns get really kind of dysfunctional when they are going down that road with those data points. So for me, I feel like there's, for the right person, that kind of at home might be helpful. I'd say probably most people need to get on it less frequently, but then really going into the office where you can have a professional sort of be in charge of that data and connect with you about what it means and how it's related to what your actual behaviors are. Because, kind of coming back to what we said up front, it's all about the daily behaviors that the person's doing at home. And that is going to have an impact on what their body composition is doing. And then you can say, let's pivot, let's change, let's do something different with the plan.
So, Nina, can we deep dive into body composition numbers? Like, what would you say, would be a reasonable, what would be a normal or a healthy fat percentage? Or do you look at where is the fat located? Uh, do you see, is it in my trunk? Is it in my thighs? Or do you just look at a 25%, 30%? What would be your cutoff like for fat percentage?
So what's interesting about the fat percentage is a lot, the numbers that a lot of people have in their head are from back in the day when they did those skin fold calipers, which
Oh
were
yeah.
measuring the
Oh yes.
subcutaneous fat. And so that's not a full picture. You're not able to measure your visceral fat around your organs that way. So sometimes people have, well, I have this number in my head. This is what someone should be. What we're seeing now, we don't have a number that like BMI, that the World Health Organization has sort of endorsed as these cutoffs for this, large population. But I'm seeing a lot around, 30% for men, 32% for women. This is from the Obesity Medicine Association. They've taken a few different numbers and they've put those together and said, here's kind of the cutoffs that we're seeing correlated with risk. The reality is we're going to have different numbers for different genders and ethnicities, because at different, just like with BMI, they're talking more about adjusted BMI for different ethnic populations. Someone who's an Asian American is much, and I'd love to hear your thoughts on this. They're much more likely to have cardiometabolic risk or events at a lower weight than someone, maybe an African American patient, who they can be at a heavier weight and still not have as much cardio and metabolic risk, and that varies. So I think we're going to see the same thing with body fat percentage to some extent, which is why we don't have a set cutoff of here's where you need, but I would say it's in the 30s would probably be the easiest number to think about. And it'll vary based on age, because we do, as we age, naturally go through sort of this natural almost sarcopenia, where our muscle mass is going down, our body fat is going up, even if your weight is staying the same. So that's a reason to use this type of assessment in everybody, not just people who have gotten to the higher end of their weight. It's good to be tracking that across the board, because then you can start to see that shift. And I think, in aging, especially in women too, we're seeing body composition changes around menopause that can be, disconcerting for people. And that's something that we think about a lot too.
So, we kind of, the weight loss medications, the semaglutide, everything it's just flooding the market right now. And it's creating a lot of different chatter. Yes, anytime, we have a decrease in the body fat percentage, your cardiovascular outcomes will improve. So we know that part. Okay. So, and yes, as you had alluded to earlier, my practice has changed. So now if I see a patient with multiple recurrent heart attacks over the years, whose BMI is above a certain cutoff, I'm like, I'm going to start you off, but you're going to have to follow up with your primary care physician for
Okay.
dosage adjustments for weight loss medications, etc. And they are definitely better than some of the older medications. But my biggest concern is actually two things. Number one, we're not changing their behavioral mindset. Why did they start eating? Why did they start having issues with food addiction? Okay, that's number one. And number two is, if they don't follow an actual exercise program, they're going to get into trouble with muscle loss, sarcopenic obesity. That's called the new term, which is now coming across, where they are getting into the normal BMI, but they're losing a lot of muscle because they are not exercising and things like that. So, what is your take on that? How do you think we can find a balance? With how do we change the behavior in a constructive fashion instead of just restricting calories?
So I think, for me, the first question, or the first sort of concept about, I don't I don't really know that we need to know exactly why they had obesity in the first place. I think there's so many different layers of genetics and behavior and environment and personal factors as well, that have got them to the place where, hey, this person's now, their body's at a bigger size, they've got excess adiposity to a level that's making them, have health conditions. So I think there's some part that's, we just at this point need a treatment for them. And the treatment doesn't right now, most of these treatments don't specifically target, like, was your obesity due to too much sedentary or too much of this or that. We get someone and we say, here's a treatment and it's going to help with weight loss. It's going to, most of these, every weight loss that you have that's significant, whether it be surgery, medication, even intensive behavioral and lifestyle interventions, you're losing weight from all the places. So we don't get to say it's just from fat. There's things we can do to hopefully, attenuate the loss of that lean mass and make sure that more of that's from fat than muscle. But we also need to kind of think about people are losing it from everywhere, and how we can address that through nutrition. But I do think it's important, especially as we're talking about medications, because they become available to so many people at this point. It's now to a point almost of there's people taking them without the rest of that interdisciplinary care team that I was part of for so long. And I can say there's a lot of lessons learned in the surgical treatment for obesity that I think we need to apply to the medical treatment. And part of that is having the support from nutrition, behavior, and exercise, even if it's not the reason you're losing more weight, right? So there's a lot of times, and there's some studies now saying the addition of intensive behavioral therapy may or may not change the
Hmm.
percent weight loss. And I think some people take that as, okay, then that's not needed. But what we really know is for like the long term, which is what we're really concerned with, people have a need for support, ideas, education, connection. There's some people who have much more in the realm of behavioral complex obesity related stuff to talk about. And there's some who it really is a lot more simple. You teach them the foods to eat and they do it, right? I those would always be patients where I'd be I'd be confused. I'm like, wait, I'm just going to tell you this is a list and you're going to do it. I mean, that was very rare. That was not how I practiced,
Yeah.
but I assumed more that we had a lot to uncover. So I think really we've got to think there's such a range. So we've got to sort of figure out what that person's needs are, find a treatment that they can try, and that it's an experiment. I mean, these days we don't have to get into it here, but there's a lot in the realm of cost, access to medication, insurance. I mean, in bariatric surgery, I thought the insurance stuff was so intense because there were so many different ways that insurance companies would try to exclude helping you with this treatment. And now with medication, there's even more. And so it's very complex in even just not just what's the right medication and interdisciplinary care plan for you, but how are we going to get it? And so that's a sidebar. I don't think that's as important clinically, but that's a big part of it. And so yeah, so I think the biggest message that I can say from a global perspective is that everybody's plan is going to be a little bit different because everybody's obesity is a little bit different, but that the overriding factor is we need to not just prescribe a medication. We need to get this, whatever we call it, comprehensive care, wraparound care, interdisciplinary care, people on the team that can help with nutrition, behavior, exercise, support when the person needs it. So I think that's my biggest take on that. And then we can tackle the body comp stuff and if you
Yes,
want.
but the problem is that's not happening. You have so many little small offices all across the country making semaglutide and making Manjaro and just selling it off, and they're not, and so many ads. You don't have to diet, just take the medication, which is complete false advertising. It just makes me so angry. I'm going to calm down right now because you're not addressing any of the problems. You're not kind of fixing anything. You're just making the patient believe, take these medications, all your weight problems will be solved. But unfortunately, it does not happen like that. And I feel like we are going to shoot ourselves in our faces, and it's going to come back to bite us in a different way. Because I don't think healthcare can afford that. To every person who's prescribing a weight loss medication to have a nutritionist, a dietitian, an exercise specialist. It's I'm not sure whether we are engineered to work that way, even though we should be working that way.
Yeah, there should be some way that our, AI or our machine learning can help figure out who needs which resources. But it's overwhelming in that space right now. And not just all the offices and the groups that are popping up, sort of doing inappropriate care with, compounding medication or medication only programs, but even the online programs, right? So there's so many of those that are just hard to keep track of, and some are fantastic. They're really attacking the core components with virtual people. They're doing, groups or like one to many kind of education. And for some people, coaching and automated, pop-up messages and things like that can really keep them on track. So there's some that I've seen that are really, really doing it well. But of course, now it's gone from this place of no one paid attention to obesity for so long, even in my career. And now it's become such a business opportunity. And that's really sad. I mean, I really feel strongly that this has to work because this is such a powerful treatment. But there's so many of these business and media factors that I feel like they're screwing it up in some way. And they're making people, like you said, they're making people on one side think, it's so easy, let me just do this, right? And like if it was that easy, like I'm all for that. That'd
Yeah.
be great if that could tackle the underlying problem and we could be in a place where people didn't have the health effects of excess adiposity. That'd be great. And maybe that will be again for some people, but the reality for more people is they may lose some weight, but it's a chronic relapsing condition,
Mhm.
right? So that they're going to have ups and downs, they're going to have struggles and people that they need on their team to navigate this relationship with food for the rest of their life. And like you said, everybody's not going to be able to supply or, access all the members of that team. And
Yes.
so it, there really is some ethical responsibility type stuff to talk about. And I think that leaches into body composition, right? So if you're a pill mill or, whatever you want to call it, where you're just prescribing people medications, I think those people more than anyone need to be looking at, am I doing this safely? Am I
Mhm.
giving someone something that's going to cause their weight to come off? Which again is if you're looking at it from a weight only perspective, I need to lose weight, I'm losing weight, that's a success. But that's not really what we're talking about here. We're talking about health. So it's not just even the access to it, it's access to all the services around it. So we have to be responsible. As that relates to body composition, I think, you really need to be looking at, are you, I don't want to say one medication is better than the other, surgery is better. Everybody's going to have, kind of their opinion on that. But all I'm saying is just measure it, right? Like have a way to accurately look at the way your patient's weight is coming off. And are they losing too much muscle compared to fat? Or is it fine? I mean, some patients present with so much muscle mass from carrying around extra weight that they have a little bit more, space, that if they lose some of that muscle on the weight loss journey, they're okay, they can build that back, or it's enough as at their new lower weight to be in a proper ratio. And some don't. And so I just, I kind of put that in the category of, let's be responsible, let's measure something that matters and that we can pivot our treatment about.
The funny thing is, whenever there's a new device which comes to the cath lab, we have so much education going on. We have so many in services, and everybody is absolutely sure we know how to use the device. What are the pluses? What are the negatives? All our
Mm.
conferences is filled with education matters. Now, there's a whole new brand of medication. Everyone is prescribing it. I wonder how many in services were happening and how much of
Mm.
discussion has happened around it. Hey, if this much of muscle mass is losing down, you may have to change treatment. Those kind of education to primary care providers or endocrinologists. People are learning out of their own interest, but I'm sure Eli Lilly or Novo Nordisk is not going and doing in services to the different clinics about how the healthy way of losing weight, whether it is fat or muscle, looks like. And that's
Mm.
really
That's a
unfortunate.
good point.
Yeah.
That's a really good point, that it isn't a device, but it is something that is pretty powerful. And
Yes.
we didn't have to deal with this before because of course there's medications beyond the GLP-1 receptor agonists in that whole category that are effective. They didn't have the extent of weight loss that we're seeing now. So it didn't have the traction and the interest that we had. So I'm with you. I think the education needs to be there. I think, it's sort of this chicken or the egg, right? Like we have so many people. I think 70% of people who have overweight or obesity, I mean that's almost everybody, right? So how do you get the trained providers to do the right thing, and it's not specialty care anymore, right?
Yes,
Like the obesity medicine folks who I was with this past weekend, they've been doing this a long time. They've been educated, they know it, but there's only, I think
absolutely.
6,000
Yeah,
ABOM certified obesity medicine folks, and so that's just simply not enough. So I think we need to think about what is baseline education for everybody, what is additional that if you want to specialize. And then there's really the Obesity Medicine Association has a new program that they're calling the treat or refer. So it's like if you have the skill set and the time and the resources to treat it, but if you don't, know your folks in the area that you can refer to so that the patient gets the appropriate care. And I think that's a nice model for where we're at right now, because there's not enough for them to do it all themselves. But we really need to strengthen these referral networks and know like where you can send someone that is not going to just give them a medication only, that is going to offer them that comprehensive care program that they need. And I think we'll hopefully get there if enough people are focusing on this. Hopefully it won't be at the expense of any safety or
absolutely.
concerns there.
And I hope, like anyone who's listening to your podcast or mine, get the message that if they are receiving these drugs from a particular provider, talk to their provider about, hey, am I good here or should I go to another person? And the provider is also magnanimous enough to say, hey, these are my limits. Let me refer
Mhm.
to you to a specialist because this is kind of going beyond my limits. And I think that requires every patient. Part of my mission is that the patient needs to be empowered to ask the right questions and empowering them with the knowledge they need to go and figure out to get what's right for them.
So are you seeing in your I know you're very well connected in the cardiology community. Are you seeing more sessions on this at your meetings, podcasts, webinars? Are people wanting this, or they is this a burden to be prescribing something new? Like what's the general like feeling or zeitgeist in your world about the obesity medications?
So it's a bit of a both. Okay, some of us have been very passionate about the holistic care of the patient, and there is patients with one of the biggest problems we have is diastolic dysfunction or diastolic heart failure. I did a whole episode with Dr. Sheldon Litwin on that,
Mm,
and it's basically related to stiffening of the heart muscle because of aging and also because of obesity. So those doctors have been gung ho about treating obesity. They've
mm,
taken ownership of treating obesity, and they love it. They love that they have another tool in their kit to treat patients. And some of us who are more procedure oriented are not. But I try to be a combination of both. So let's say if I have a patient who has a bicuspid aortic valve and eventually need open heart surgery, and his BMI is increasing and body waist circumference is increasing, I'm going to start you on it because you have a marathon, which is your open heart surgery, which will happen to you in the next 5 to 10 years, and you need to be ready to run that marathon. So we're not going to deal with this problem 10 years from now. We're going to start right now so you're ready. So I think it's a mixed bucket, but we are taking more ownership of it. Obesity is truly a no man's disease and every man's disease, like,
mm,
right? There's a obesity medicine certified doctors, but in the past everyone was treating obesity, right? So it kind of goes there. So now endocrinologists are taking ownership, cardiologists are taking ownership of it. And but even then, like, compared to the amount of training we got with prescribing statins or our clopidogrel or prasugrel or any of our other cardiac medications, the training we have received for these medications will be zero. Okay, those guys were
yeah.
always there, and it's a good and a bad thing. You don't want industry changing your mind, but I think if they, and maybe industry does not know, they themselves, they are figuring it out as they go right now. And I think the onus might be on us physicians to come up with a safe way of how, when are the red lights, like there's too much muscle loss or something like that. We may have to
Mhm.
come up with the parameters, and we don't have those answers as yet.
So where do you think the best sort of target is? That through clinical practice guidelines? Is it through education, through, meetings that you go to, webinars? Like, how are people gonna, you know, the majority of people in this field, how are they going to get the message? Is it through industry education around the medication?
It has to be everything. I think we need better guidelines. That's
Mm.
the bottom line. Obesity medicine or management of obesity has been so muddled or so confused with so many different things. We need better guidelines as to an algorithmic approach to treating obesity with
Mm.
medication. So if you have and that I am yet to see a paper on that. Maybe I should push Rana to write one on that.
There's it. What I'm seeing too is a little bit of everybody's got it in their own professional organization, but I think part of the answer, more globally, is that the organizations need to be working together, because right now it's, these are indicated in diabetes, in cardiology, in sleep apnea, but I mean, as more and more studies come out and as more and more medications come out, I'm sure we'll see other disease states impacted. And so I think we kind of jump out of our silos a little bit of our disease state. Like you said, 70%, that's everybody's business. And
Yes.
how do we unite that so that it's not in pockets? And then I think the comprehensive and interdisciplinary part is important too, because again, if you're an interventional, proceduralist, counseling a patient in a clinic shouldn't be a majority of your time, right? But do you
Absolutely.
have that on your teams? Like, is that a big gap for
So,
you?
oh, a big time. Like I run late on every patient of mine because I talk too much about things I'm not associated with, but it needs to be done. Like,
Mm,
I had a 41-year-old patient who had a massive heart attack and rushed to the hospital and, did the procedure, etc. His hemoglobin A1C was just 13. His BMI was like I don't know what to call this. It was about 35. So this is a young obese patient with uncontrolled diabetes. And I open up his blood vessel, put the stent, and I'm like, hey, everything went well. You're doing a okay. He's like, how did this happen to me? I'm like, are you kidding me? Like, how are you even asking me this question? Because anyone who has uncontrolled diabetes has blockages in their blood vessels unless proved otherwise. That's the norm because that's how prevalent it is with when you have diabetes and when you're, so I was like, are you kidding me? So no one's actually spoken to you
mm,
about your heart risks or any of that. So his healthcare awareness of his own personal medical conditions was so limited. So
mm.
it is the overall literacy is very lacking, and I think that's what we're all trying to achieve with these podcasts. But again, we are putting the ownership on the patients. Only the people who are worried about their health will come and listen to these podcasts. But we want to reach the people who are not worried about their health to start being more aware of their
Yeah.
conditions. Right? That's the challenge. I think you know. I see patients after a heart attack, and that's too late because we need to be seeing them or we need to be catching them before they have a heart attack. And I honestly, if it was up to me, I would start this healthcare literacy programs in high schools
Mm,
or in middle schools. And, how many times when you got a new car or when you started driving, either one of your parents told you how to take care of the car, right? How many times to check for gas, maintenance, and everything. Who does that? Who does that when it comes to your own body? And by the
that's
time
a
they
way to
teach
put
you,
it.
yeah, by the time you learn that, you already have habits formed. You're already addicted to different fast foods or different sugary things or different sodas, or you're already into smoking or vaping. So, we need to change the way we are doing this. We are not
Mm.
doing it the right way.
That prevention part's big, and I think for those of us who, like, I think bariatric surgery and what you do is sort of, we've learned a lot because that's the more severe disease state. There's a lot of lessons learned of what we could do earlier. And so from a cardiology or metabolic health risk perspective, what are those screening things that do people just have to wait till someone checks their cholesterol? Is that the first step usually, or what are the real precursors to your world?
The first thing is to check your waist circumference. That's all, waist circumference. So in general, American the Internal Medicine Society has very strict prevention guidelines. Okay, there's American Prevention Society task force itself. So in general, every year checkup, but once you hit the age of 30 or 35, you start getting yearly blood cholesterol, but you also need to get your waist circumference checked. And if your waist circumference is more than 36 inches, then you start having other screening tests done. Okay, and that's when the counseling happens, the dietary counseling happens, and the measurements can be different for men and women and for
Right.
different ethnicities. I think I'm just giving a general idea. And that's when, but the problem is the primary care physician is like, oh yeah, your weight circumference is increasing. You need to start losing weight, eat less, exercise more. Okay, I'll see you
Gross.
next year.
Yeah.
That's all time they have. I mean, we are
Yeah.
manned by work revenue units, and we are manned by all the insurance companies asking us to check off boxes, etc. It's very constraining. It's very constraining for a physician to have elaborate conversations.
Right.
So that's why I think we need a non. This needs to be done outside the clinic. It needs to be
Yeah.
done in educational spaces or something like that, so
And
that.
even by the diet, I mean, I always say as a dietitian, I'm like, oh, you don't have to learn all this stuff. There's a whole profession of people who, we do this. It's just we have to know that each other exists and how to merge these pathways
Yes,
too.
yes,
But yeah, I like the idea of being, outside of healthcare too, because we know that people are going, we know how much time they're spending, this is a whole nother conversation, right? On their phones and interacting with health information online. But I did want to come back to waist circumference because I think that's another important measure of, hit somewhere between BMI and a fuller, more, body composition assessment. But we have our providers measure waist circumference, and actually the waist circumference surface area measurement goes into the prediction equations for estimating visceral adipose tissue,
yes.
which is validated with MRI data. So for us, that's a huge kind of connection between cardiometabolic health and not just weight, where we're saying waist circumference is something to measure, and here's another measure that we're kind of able to give some insight into. And I think those are the ones that I would also suggest to be looking at over time. And if you're seeing that visceral adipose tissue increase or get into those higher levels, that would be another indication of a need for treatment, even if, I mean, we see those levels be high even at someone at a normal weight.
Yeah. So something, I'm sure you've seen this. Most people know that they have a problem. Okay. People know, okay, my waist is really big. I'm carrying a lot of weight around my waist. I am definitely obese, but I don't want to go to a doctor. I don't want to get checked, because if I go get checked, then they're going to say, 10 different things that are wrong with me. They're going to want to change my whole lifestyle. What
Hmm.
would you say to that person? How would, as a behavioral psychologist, like, what can we say? It's okay. We are not going to hurt you.
There's also adding onto that, there's a lot of distrust in medicine and, medical industry. And there's a lot of people who think we're out to just put medication on people too, right? I really would say that majority of the providers that I've interacted with in my career really do abide by a patient-centered, person first kind of a strategy where we're going to meet you where you're at, right? I've heard that, thankfully I've heard that so much at conferences where, it's really this evidence-based practice paradigm where we're taking, like we started talking about, the best available evidence, but that's just one factor. We're taking our own provider experience, and then we're big time taking patient values into the equation. So I guess I would tell a patient that, while there are guidelines and there are metrics out there that might be the best or what people are recommending you to do, there's a lot of space in between where the provider is going to meet you where you're at and help use some counseling strategies to help you move your own health forward on a spectrum. But it's not like a cutoff where you're either healthy or not healthy. It's more of a relationship and a long term journey rather than just a you are or you're not. And so I think there's a lot of layers of black and white thinking that we've got to get out of. It's, not just the best research and everybody's got these strict cutoff guidelines. And if you're under it, the providers need to do a better job, really explaining that too, and using the limited time that they have to say, yeah, well, this may be the guideline, you're way over here. And so you don't go from there to here overnight. And here's how we will support you in that journey. So I think to some extent, patients need to have more positive experiences with providers who have that approach so that they start to trust that and know that, they're not going to come take everything away from you. That's not how it works. But you're right. That's a big barrier for many. And a lot of providers strengthen that barrier with their top-down advice-giving approach, and they don't take the patient-centered, pathway. So,
So, my podcast is called Reboot with Dr. Arasi Marin. So, I'm going to ask you for a personal story where have you had to ever reboot yourself, or are you planning on anything like that? Or what is your experience with rebooting?
I like that. So for me, I rebooted my whole world 2 years ago when I changed jobs and personal life situations and all of that, and dove into body composition from clinical practice, where I was talking to patients all the time. That was a big reboot. Now I would say the more I talk to providers, the more I look at my own data when I'm on our body composition device, there's a lot of work I need to do in shifting my own mindset towards muscle health, right? Like I'm in my low 40s, my birthday's next week. And so I know that as I get older, my muscle mass is going down, my body fat's going up. And while I'm sort of, psychologically okay with those shifts, my physical health is going to be improved if I can get that muscle mass up. So for me, that's been a recent goal, is to figure out how can I build up my muscle mass and age a little bit better from that perspective.
Fantastic, fantastic. So, where can we find your body composition machines in Charleston or around?
Well, you can come straight to my office since we're down the road over here. So our headquarters is in Chino, California, and Mount Pleasant, South Carolina. That's where we sort of all have our offices, and we do have some virtual folks around the country. But we have body composition devices in, outpatient doctors' offices in all types of areas. So from direct primary care to traditional primary care, to obesity care, whether that be medical or surgical. We have a lot of functional health providers using body composition. It's even in some of the kind of what are they called? Like spa at medical spa
Oh,
situations. People are looking at it there. I've even actually this week, the CF program, cystic fibrosis program at MUSC, is getting one because their patients are seeing shifts in their body composition with the new medications they have available. So I would say specialty and general offices, this is where you would see it. We're also seeing it expand. We have a whole line that's in fitness centers and gyms, because that tended to be where people focused on that before. So I think you'll still continue to see that. And I've got lots of ideas at other, direct patient places that we should have it. It's just a matter of who owns it and who's
taking
relaying
responsibility.
the device information to that patient. So our kind of main website, SICA MBCA, so medical body composition, that's a place to go to sort of, get any resources and connections that we have. And I'm, as an individual, I do a lot of education for the providers. So if you've got providers listening, LinkedIn, Nina Crowley on LinkedIn is probably the best place to get my thoughts on all of these things. And yeah, I'd be happy to share, what's the best way to connect with you in your podcast.
I'm available on all places where podcasts are available. I also have a website, drarasimarin.com. So that would be a best place. I practice in MUSC. I'm not giving medical consultation beyond my scope in practice of MUSC, but I'm happy to chat about, any cardiometabolic health questions. I'm on Instagram, LinkedIn, all those places. Before we finish, I have one important question I have to ask the registered dietitian.
Okay.
Great of you. What's the best diet, Nina?
I can't. Did you listen to the whole podcast? Come on.
That was a trick question, but
Okay,
I'm
good.
sure people are like, what is the best diet? What is the magic diet?
I
Okay.
think, the old adage used to be like, what's the best exercise to do? Well, the one that you will do, right? So for me, the best diet for the person who's in front of me asking that question would be the one that you can feel full, not have intrusive thoughts, enjoy the food that you're eating, minimize any of the negative psychological stuff around it, but enjoy and be at peace with your food and your body. So how we get to that place, I mean, I would say get a dietitian or an interdisciplinary team around you to help support that, because your issues may not just be around choosing the right food. They may be around, kind of the behavioral or the exercise or the lifestyle, or you may need medication and surgery, and none of those are moral failings. They're all just part of a support. We would never, right? You don't see patients feel ethically conflicted about taking a statin, right? I mean, that's just part of, you have a disease, you take the medication, and you do the lifestyle things, and we measure your outcomes and we take it from there. I would
Absolutely.
love to see nutrition and obesity get to that kind of a place one day.
Fantastic. Thank you so much, Nina. I learned so much, and I am going to stop by your office and get my own body composition checked out,
Yes.
and we'll go from there.
Well,
Thank you.
maybe we can lift some weights together, because I may need a
Oh, I
partner
love
in
it.
that.
Yes. Oh, yeah. I'm all about strength training right now. So, yes.
Well, thank you so much. It was a pleasure talking to you today.
Yes. Fantastic.